So let's jump into our first case study. And before we get started, I just want to warn everyone that while the goal here is to have everyone participate in the comments and share good information, I do not want this to turn into a name-calling fest. So as long as everything stays civil, we'll keep everything up and running. If it doesn't, this will be our first and last case study. I'm not pointing any fingers at anyone, but I know that some of us are very passionate about what we do, and sometimes even more so passionate about the lessons that we know or the things that we think we know. We don't embrace change often. So having said that and gotten it out of the way, let's jump right in. So here's the event. You are called to a 73-year-old male. Patient was at a particularly vigorous church service when he had an episode of near syncope and diaphoresis. Patient takes a seat. They call 911 for him. He feels better after he cools down, which is about the time EMS arrives, and he initially refuses transport. So the first thing's going through your mind here. I'm curious. I'd love to hear about it in the comments, or you can just send messages straight to us via the Facebook or the Gmail. So let's dive a little deeper. After some coaxing, the patient is compliant and allows EMS to check his vital signs and things like that. So getting history, he does have a history of hypertension. He is compliant with his meds. He is now on amlodipine twice a day. He did take hydrochlorothiazide in the early days, right after diagnosis, and then had a bad response to it. He lists it as an allergy, but we don't really see anaphylaxis in the history. So he did also have an MI about 1 year ago. It was an inferior STEMI. He had a stent placed, and he sees his cardiologist regularly. He states he's compliant with all of his appointments and things like that. All right, so here's your baseline vital signs. You got a heart rate of 78. Respirations are 22. They're not overly shallow or labored or anything like that. Blood pressure is 110 over 80. That's manual. O2 saturation is going to be 97% on room air. Glucose is 108. His temperature is 98.9 or 31.6 for those of you using the centigrade system. Here is your EKG. So let's take a look at this. I did leave the monitor interpretation up here so everyone could see and make as good of a decision as they could, but also it's good food for thought. And in the actual reveal of this case study where we show admission diagnosis and everything like that, we're going to speak a little bit more about this. But for now, take the time to look at it and pause the video if you need to, and then let's talk about some of the clinical decisions that you would make for this. So what's appropriate for this patient? If this is your patient, whether you work in an ED or whether you're on an ambulance, what are your immediate steps? What are you going to do? Do you think IV access is necessary? If this patient, agrees to transport, or if this patient were to walk into your clinic, is IV access necessary? What do you want to do? What about oxygen therapy? This, he's a little tachypnic. He did have an episode of near syncope. How do you feel about that? And then, of course, do you provide medicines? Are you going to treat? Or more specifically for the pre-hospital guys, is this a chest pain protocol in that just-in-case phase of things that we see given fairly often, probably a lot more often than we would like to? So how are you going to approach this patient? No answer is too detailed. No answer is too short. Let's all jump on here together and exchange some information. And after we've had a little bit of time for everybody to participate, and when things start winding down, we will do a case reveal and we will show admission diagnosis labs, all that good stuff for this patient, where we can make a better educated decision in the future when we encounter patients similar to this. All right. So for now, just take some time to think about it. Thank you for watching and get out there and practice.